Assalamu alaikum. Good afternoon, ladies and gentlemen. So this case regarding our patient, Mr. S.A., who is a 39-year-old gentleman, presented to our ER department complaining of typical chest pain of myocardial infarction, which was started about 2 hours before of his presentation. So he is not known to have any chronic medical illnesses before and no previous hospitalization for any reason. He's not smoker or drug abuser, no family history of premature ischemic heart disease, and his initial vital signs when he present was as the following. It's almost stable. So this is the first ECG in the ER at the time of arrival, showing extensive anterolateral MI with involvement of the lead 3 over the inferior lead, could be sounding the big LAD wraparound. So being not 100% primary PCI center, so we take the decision to give fibrinolytic therapy. TNK was given within less than 30 minutes from his presentation to the ER. And this is the initial lab results after TNK was given. So this is the echocardiography bedside, echo immediately after TNK. And you can see here that there is a moderate LV dysfunction, ejection fraction, it's about 35%, with a pattern of injury involving the LAD territory. So after 90 minutes post-TNK in the CCU, patient still had chest pain, about 5/10, whatever. There is a language barrier, but it's still there is chest pain, and the ST it's not resolved by more than 50%. So decision taking to go for the next step, which is rescue PCI. Right radial approach, opti-torque catheter, Tiger, and that's what we find. There is a huge thrombus involving the distal left main and the proximal part of the LAD. There is like TIMI2 flow up to the distal part of the LAD. RCA is normal. So that's our thrombus here.
Okay, so why don't we stop here then and ask the panel here. So this man, he failed lytic therapy. He came with some chest pain, no full resolution of the STs, or at least not 50% or more. And he is faced with this. What would be the approach here? What would the panel, and TIMI2 flow, not a great blush, so there's a good reason for him to actually still have chest pain.
Interesting thing in this patient that the initial or the first electrocardiogram showed that he sustained an anteroceptal infarction, Q waves from the start even before the thrombolytic therapy. Okay. The second thing which is interesting in the coronary angiography, the smooth vessels. There is no evidence of plaques, no evidence of significant atherosclerotic burden, just only a thrombus burden, which necessitates the use of thrombectomy, mechanical and pharmacological approach, doing thrombectomy with the use of 2B3 receptor antagonists.
So you would, Dr. Majid, you would actually try and extract this clot?
Yeah.
Dr. Ramzi?
I would do mechanical aspiration first, and then take another shot and see where we are. But I would definitely aspirate the thrombus to start with. Yeah.
Dr. Samia?
He obviously trashed his myocardium already with the thrombolytic. Apparently, it did not give him a clean result. I mean, there is flow, no doubt. So some improvement had happened.
Yep.
So either I, in a way, invest in the fact that he already improved. All what I need is more time, and things should get better. And then I will go pharmacological, or I will go to thrombus aspiration if I felt it is going to threaten the outcome.
So he, with this picture right now, you would extract it, or you would leave it?
In the left main, extracting a thrombus is very risky towards the issue of strokes. So I would say I've done it once where I put actually my guider inside the thrombus. I pushed the guider towards the left main and I did suction. This probably I would do, but I will not use a typical suction catheter.
Dr. Ahmed, what would you do?
It's just very hard. Actually, what I will do, I will try to avoid touching this thrombus, especially that extending to the left main. I might just close everything. It might go to the circ, and then I will have bigger problems. I will just stop, give 2B3A, heparin, and bring him back
So
later
don't
on.
rock the boat. So how many in the audience here would actually proceed with or attempt to actually extract the clot in the left main? Show of hands. Who would actually extract it? Who would leave it alone?
Oh, God.
Okay. Dr. Muhammad, تفضل.
The idea of thrombolytics or the primary PCR is the restoration of TB3 flow or myocardial blush. Am I right?
صحيح.
The second, if there is a lesion, you have to passivate the lesion. So for the first, you have it. For the second, you don't have a lesion. You only have a thrombus. The pain of the patient is not from this thrombus or from distal embolization, which happened from the thrombolytic therapy. So the idea behind is to relieve the pain. For the ECG and the echo, V1 and V2, we have an embryonic R. Only still we have some raising in V3 and V4. This raising because of distal embolization. So the aim is to relieve the pain now. So just by nitrates, and don't give 2B3A, because 2B3A after thrombolytics, the patient will die from bleeding. So continue the aspirin, clopidogrel, ticagrel, low molecular weight heparin with nitrates, as long as the patient is stable, 2B3 flow, good myocardial blush, good myocardial function, and then repeat the control angiogram on discharge. This is my policy with this patient.
Dr. Khalid, Assalamu alaikum. Well, I agree that probably using 2B3A after thrombolytics is a little bit risky and also can cause bleeding. But I think in this situation, I would believe it's safer than sucking the clot with the thrombolytic, with the aspiration catheter, because I've seen, and it happened to me, that actually after sucking the thrombus, it actually went into the circ and caused another acute MI. So I think you're in a tricky situation, but I think the safest thing is to give thrombolytic therapy. To give 2B3A.
Yeah. I think the comment that was made earlier that really what is the cause of the patient's chest pain, it's not that thrombus, it's probably no reflow in the microcirculation level. There's not a good blush. So really aspirating it might actually worsen things, might rock the boat, may make things worse. Okay, so let's see what you've done, Dr.
For
Raed.
all reasons that my colleague mentions, at that midnight, I don't want to bother that thrombus there, then I will suffer my night with that. So the decision was just to continue double antiplatelet therapy, glycoprotein 2BA inhibitor for another 44 hours, low molecular weight heparin, CCU admission, and recath after 48 hours if there is indication. So that's what would happen. And we continue for 48 hours, then we call the patient for cath again. The monster's still there at the left main and proximal LAD. Yes, TIMI flow now, it's better comparing to the first time. Not completely occlusive. We have a distal flow in a very nice way. So, but the thrombus is still there.
It's a smaller one though.
Smaller, yes, but it's still there.
Bit too early. You came back to him too early. I usually take longer than 72 hours even.
It's 48 hours, yes, actually, yeah.
Did you consider IVUS?
So now the thrombus is still there.
So the question, Dr. Samih, you're not happy with the duration of observation. You want longer. طبعا Dr. Ramzi, Dr. Majid, you would have actually acted on this from the start. And Dr. Ahmed, you were also conservative. What would you do then in this particular case? Especially with these eyes and...
Basically, I will continue conservative. I don't see any acute rupture plaque there. I mean, we see thrombus there, but the artery is smooth.
Yes.
So I will continue with conservative, basically. I will not touch it.
You will not touch him. So again, the question here, can I have a show of hands? Who would intervene now and do clot extraction? Show of hands. Nobody. One. Who would actually leave him alone?
Oh, good.
All right. So leave him alone meaning medical therapy, obviously. So the question, the next question is, if you want to leave him alone, would you actually keep him on 2B3 inhibitors and heparin for a few days? Would you be happy in about 2 or 3 days? This is day number what?
This is actually day number 3.
So day number 3, so the 4th or 5th day, you would send him home. How many would send him home on the 5th day on dual antiplatelets and that's it? Dr. Haytham, full weight. What's the evidence for that? Okay.
Okay.
All right.
Yeah.
Hussam, any options for
Dr.
IVUS?
Dr. Abdullah wants to...
Could be any spontaneous dissection because there is no risk factor, because no IVUS was done to demonstrate well the lesion.
Right.
Because I saw in one view there is possible coronary dissection.
Right.
In one of the views.
So the panel here, anyone thinks that this is a dissection based on the angiographic results, just by angiography? Any suspicion of a dissection here?
Without the use of IVUS, we cannot tell.
Yeah.
So, yeah.
This is difficult. So some people would like to have more imaging. Okay. Any other thoughts, Dr. Khalid? Faraidi?
He's a young guy with this monster, and I wouldn't feel comfortable sending him home. I might keep him in low molecular weight heparin or IV heparin in hospital.
For how long?
For a week maybe, and look.
Would you cath him again?
Sure, of course, I'll cath him. I need to see what's happening. I'm not feeling comfortable sending a patient, young guy, with this.
Dr. Blankenship, would you want to comment? Dr. James?
I think low molecular weight heparin for 2 weeks is a great idea. Might add in Coumadin as well as a dual antiplatelet therapy and keep him on Coumadin for several months. I would not recath him as long as he was doing well clinically.
Okay.
Yeah.
So Dr.
I think I will leave him to go home after 1 week or 5 days in low molecular weight, but I have to study the cause of the thrombus because this is a young guy with smooth vessels, so it could be antiphospholipid syndrome or it could be vasculitis. It could be something which make it, this is a smooth wall with a young man. Sometimes rheumatoid, I saw a lot of rheumatoid patients with this kind of thrombose. So it's leave him alone now and then study the patient after that.
Okay. So,
for the sake of time, can we move? What did you do, Dr. Raed?
okay, then actually, considering most of the point my colleague mentioned, we even searched the literatures. What's the best answer for this situation? What I should do after that? It's honestly, there is no clear answer. What the next step should be. So I discussed the case with some of my colleagues, then we finalized that by discharging the patient, being stable day 5. He was on low molecular weight heparin for all of those 5 days, free of chest pain on double antiplatelet therapy, including ticagrelol and aspirin, and follow up him in the clinic after 2 weeks. Wrong, right, no evidence for both of ways. So patient first clinic visit, he was completely asymptomatic with stable vital signs, and this is his ECG. So actually, he looked better now. So we keep follow up him. After 2 months of regular follow-up, patient one day, we actually asked the patient to just drop in if he had any kind of abnormal symptoms to him. So he presented to the clinic complaining of chest pain. Honestly, it was atypical, but there is a significant ECG changes. So now there is a dynamic STT changes, T wave there. Actually, because I know what was the monster there before, so I don't feel comfortable to just ignore the atypical symptoms. I decided to admit him, and immediately we did echo, and here the surprise was started. You can see dramatic change in his echocardiography now. Actually, ejection fraction now it's low normal, it's 50%. And the pattern of injury in the previous segment, it's almost normalized with the preserved thickness. So I decided even to cast him to see what happened. And you can see now the thrombus, it's not there. Whatever there is a residual disease, it's like in a 20%, but the thrombus, it's not there anymore. And the TIMI flow is completely normal. Reminding this is previous and this is after, this is previous and this is after. So I think sometime less can be more. That's what I conclude after this case. Thank you, everybody.
Thank you.